Hello. We'll just once again, good morning to all of you and welcome to this program on manual therapy for the knee. Before we go to the topic, let me discuss a little bit on the anatomy and biomechanics of the knee joint. You know, knee joint is a synovial joint of condylar variety. It has got two articulations, tibiofemoral and patellofemoral. Coming to the tibiofemoral joint, you know, the upper part of the tibia has got two condyles. The medial condyle is larger than the lateral condyle. Actually, the medial condyle is concave in all directions, whereas lateral condyle is actually convex anteroposteriorly and concave mediolaterally. This tibial articulating surface is deepened by the fibrocartilaginous meniscus. You know, meniscus is a fibrocartilaginous structure which is triangular in cross section and attached. You know, the anterior horn is attached in front of the intercondylar eminence, and the posterior horns are attached behind the intercondylar eminence in the intercondylar area. The anterior portion of the menisci are freely movable. They move, you know, they glide anterior to posteriorly during knee flexion, and they glide posterior to anteriorly during knee extension. The menisci move with the tibia during knee flexion extension, and it moves with the femur during rotation. More detail we discuss later on. Now coming to the femur, you know, the lower end of the femur has got two large condyles separated posteriorly by the intercondylar notch, and anteriorly there is patellar notch to which the patella articulates. The articulating surface, if you look at the articulating surface on the lateral aspect, it extends more proximally than that on the medial side. Because, you know, as the knee extends with quadriceps contraction, the patella glides upward and laterally. So, as the patella glides upward and laterally, that is the reason why the lateral articulating surface on the lateral condyle of the femur extend more proximally than that of the medial. So, during this tracking, you know, upward and lateral tracking of the patella, there is a chance of the patella to get subluxated laterally. So, to prevent that, if you look at the lateral femoral condyle extend more anteriorly. There is an anterior projection that prevents lateral subluxation of the patella. And dynamically, the lateral subluxation of the patella is prevented by the vastus medialis obliquus. If you look at the femoral condyle, you know, the medial condyle extends more distally than the medial. As a result, you know, in standing position, you find there is a genu valgum of about 10 degrees. So when there is a genu valgum, you know, the weight line should shift. In case of genu valgum, the weight line should pass on the lateral tibiofemoral compartment. That means there is more of lateral compression and medial side. Lateral compartment is loaded more, ideally, actually, there should occur degeneration of the lateral compartment of the tibiofemoral joint, but it doesn't happen. Most often we find degeneration of the medial compartment. However, it is so, again we'll discuss it later on. If you look at the lateral aspect of the femoral condyle, you know, it is not part of the circle. It is rather part of the circle. If you go anterior posteriorly, you find that the femoral condyle gradually. That is, the anterior portion is part of a larger circle, and as you go back, gradually the radius of curvature gradually decreases. During, you know, extension in the closed back position, where the tibiofemoral contact is maximum, the joint is maximally congruent. So when the knee is loaded in extension, the load is equal to force per unit area. In the area of contact is more, the load is minimum. And as the knee flexes, gradually progressing, knee flexion, the smaller diameter radius of curvature of the femoral condyle articulates with the constant tibial condyle. Tibial articulating surface is constant, but with progressive knee flexion, the radius of curvature of the femoral condyle gradually decreases. So as a result, what happens? With knee flexion, progressively the knee joint becomes incongruent. The contact area is gradually decreasing. If the knee is loaded in flexion, the load is going to be gradual more. The load, you can say, is directly proportional to knee flexion angle. More is the knee flexion, more is the loading. That is the reason a person with degenerative joint disease, usually we advise them to avoid all activities, weight bearing activities with the knee bending. Then, coming to degenerative joint disease, we will discuss degenerative joint disease because knee joint, the common problem in the knee joint is since it is a biaxial joint, but it can freely move in sagittal plane for flexion extension. There occurs slight rotation in a semi-flexed knee. Maximum about 30 to 40 degree of external rotation occurs when the knee is flexed to 90 degree, and internal rotation 20 to 30 degree occur. Maximum 30 degree internal rotation occurs when the knee is flexed to 90 degree. So since knee joint is, the mobility is freely movable in the sagittal plane, when force act in any other direction, that may cause injury, like valgus stress lead to injury of the medial collateral ligament. If there is any rotational stress, that may lead to meniscal injury. And knee joint is also common site of degenerative joint, most common site of the degenerative joint disease. The reason we have discussed, when one bear the load with the knee flexion position, load is more, and over time that lead to degeneration of the joint. Normally what happens? We load our knee joints in extension position. During normal human locomotion, at mid-stance, the knee joint is about 10 degree of flexion. If somebody has got a knee flexion deformity, he has to load the knee in a hyperflex position because he cannot attain 10 degree of extension. So by loading the knee in hyperflex position, during each mid-stance phase, the load over the tibiofemoral joint is increased. That predisposes to progressive degeneration. So that is the reason when patient come to us with any arthritis problem, maybe degenerative joint disease or so, in that case, correction of the knee flexion deformity should be our first aim. Our aim is to provide full knee extension so that during normal human locomotion, at the mid-stance phase, he should be able to load the knee in normal, that is 10 degree of extension position, which is close to close back position. If the knee is loaded in flexion, which is incongruent, where the contact area is less, that is going to lead to progressive degeneration. Usually, patients with knee deformity and all, they bother for the knee flexion. They say, my knee is not bending, I want to sit, I want to squat. But you have to educate the patient, see, if your knee bends, yes, you could be able to sit, you could be able to squat, you could be able to climb the steps easily, but that will result in progressive damage of your knee joint. So to protect your knee joint, extension, straight knee is very, very important. So you have to convince the patient and correct the knee flexion deformity. Now coming to joint disease, degenerative joint disease or osteoarthritis of the knee joint, it is the progressive degeneration of the articular cartilage. Articular cartilage is a avascular structure. It is a neural structure. It doesn't have the blood supply. So once it is damaged, once it is injured, it cannot be repaired. It cannot be replaced. Then how it derive its nutrition? It derive its nutrition from the synovial fluid. The synovial fluid to be secreted into the joint. Movement is essential. Fresh synovial fluid should be secreted inside the joint, and the used synovial fluid should be removed out of the joint. So for that, we require a pressure gradient. That is, when the intra-articular pressure becomes positive, synovial fluid is dispersed out of the joint, and when the intra-articular pressure becomes negative, providing nutrition to the avascular. This articular pressure changes. As the knee joint moves towards closed pack position, at closed pack position, that is the 0 degree of extension, the intra-articular pressure is maximum, the resting position, intra-articular pressure is the minimum. When the knee moves towards extension, gradually the intra-articular pressure becomes positive, synovial fluid is pushed out of the joint, and when the joint moves toward the resting position, that is towards flexion, intra-articular pressure becomes negative, and fresh synovial fluid secreted inside the joint, providing nutrition to the articular cartilage. So, what I want to say is essential for a healthy articular cartilage. If a person is given rest, or maybe colon surgery, colon trauma, this fluid exchange doesn't take place. The in and out of the synovial fluid doesn't occur. The synovial fluid inside the joint. So, and that's undergoes degeneration. Now coming to the articular cartilage, this articular cartilage alternate compression relaxation of the articular cartilage. Squeeze out. And when the articular cartilage is relaxed, providing nutrition. Then how the alternate compression and relaxation of the articular cartilage occur? That occur again. As the joint moves to a closed pack position, the articular cartilage is compressed. Joint space is the minimum. Joint volume is the minimum. And when the articular moves from the resting position, the articular is relaxed and derives the nutrition. Similarly, when wearing the articular
Sir, sorry for interrupting, sir. PP, sir.
Yes.
Sir, your voice is not getting clear, sir. It is breaking, sir. Your voice is breaking, sir.
Okay.
Hello, sir. Your voice is breaking, sir.
Okay.
Please adjust your mic, sir.
Now, coming to the pathological process in degenerative joint disease, the pathological process, it starts with the loss of mucopolysaccharides. Degenerative joint disease or osteoarthritis in the knee is thought to be due to aging. Primary osteoarthritis is thought to be due to aging, but it is not so. It is not due to aging. The non-articular portion of the articular cartilage should undergo degeneration. But actually, the articular cartilage, which is subjected to greater compressive load, the area that comes in contact with each other, that undergo degeneration to the maximum extent. So that aging theory is not acceptable. Then people say the person with over body weight, they like to develop osteoarthritis, but again, not all obese or obese individual get osteoarthritis, whereas some thin and thin person also could get osteoarthritis. So, then an experiment has been performed in rabbit's knee, which are subjected to load to the body weight 1 hour per day at the frequency of 60 per minute for 1 month. And after 1 month, they found that there is gross osteoarthritic changes in the rabbit's knee. So from this experiment, and it has been concluded that definitely it is the load which is responsible, but it may be the type of load, how the load is, the individual load the knee joint. What is the nature of activity? What is the occupation? If the individual load the knee joint, if a thin individual load the knee joint in an incongruent position, his occupation, his activities involve more of squatting, step climbing, sitting on the floor, standing, etc. The joint where the joint is loaded in incongruent position, even if his lean and thin, body weight is less, is likely to develop degenerative joint disease. And when the over wet person or obese person, if his activity is not in incongruent position, it doesn't involve in more of weight bearing activities in non-weight incongruent position, he may not get degenerative joint disease even if he is obese. There are certain other factors like the muscles. If the periarticular muscles are strong enough, they can support the body weight to some extent and the joint can be deloaded. One of the excellent means to deload the joint is eccentric work of the muscles around the joint. That, you can say, for the information of the students, if you are jumping from a height with the knee bent and you are jumping from height with the knee straight, same height with the knee straight, you are not hurt when your knee is flexed, but you are hurt when your knee is straight, because that ground reaction force that causes bending of the knee, which is controlled by the eccentric work of the body muscle, thereby your joint is protected. You are less hurt. So that explains how eccentric work of the muscles support your joint. So strengthening of the muscles is also very important. And we have already mentioned, if somebody has got a knee flexion deformity, that needs to be corrected so that the weight bearing will be in an congruent position and joint loading can be minimized. Now coming to the pathological process, this is start with the loss of mucopolysaccharide. The mucopolysaccharide absorb the water. So with the loss of mucopolysaccharide, the water content of the articular cartilage is reduced proportionately. When the water content is reduced proportionately, the energy attenuation capacity of the articular cartilage is reduced. That means now the cells will be subjected to greater load. I'll say, if you are jumping from height to a land, you are jumping from height to the water body. When you jump to the water body, that attenuates the energy, you are less hot. If you are jumping from the same height to a land, you are hot because the energy acquisition capacity of the land is less. So that is what I want to explain. The tissue having more water content has got more energy attenuation capacity. So with the loss of mucopolysaccharide and the water content of the articular cartilage, now the cells will be subjected to greater load. The cells may fail to withstand the load and there occurs cell death. The area which is subjected to greater compressive load, the articular cartilage undergo degeneration, there will be necrosis. The necrosed articular cartilage will be detached from the parent body, then develop a fissure. The articular surface becomes rough. There will be crepitus during the movement. The necrosed articular cartilage needs to be removed out of the joint. That lies inside the joint as a loose body. So that needs to be removed out of the joint. And to remove it, to clean it out of the joint, there occurs synovitis. Degenerative joint disease is a slowly progressive process. It occurs over years. So, this process is chronic in nature. Very rarely, acute synovitis may develop when a large portion of the articular cartilage is necrosed, or somebody is involved in some overactivities, undue activities, unaccustomed activities. In that case, synovitis, acute synovitis may develop. Otherwise, it is a chronic synovitis. And that ends once the joint is clean, synovitis is resolved. Articular cartilage is avascular with poor metabolic capacity, cannot be repaired, cannot be replaced. So there occur compensatory fibroblastic proliferation, there occur compensatory bony proliferation. It is lying down of the collagen fibers, resulting in fibrous thickening of the joint capsule, and the movement is going to be limited in a capsular pattern. In the knee joint, capsular pattern is both flexion and extension are limited. Flexion is limited more than the extension. Terminal 20 to 30 degrees of extension is limited, and flexion beyond 100 degrees or so is limited. Then degeneration progresses with advancing age. Degeneration progresses, and gradually it involves the subchondral bone. Articular cartilage is aneural. So when a neural articular cartilage is degenerated, damaged, or whatever, one is not supposed to get the pain. But in osteoarthritis, how the patient complains of pain? And when the subchondral bone is involved, subchondral bone is richly supplied by the nerve ending. So one gets continuous pain. Pain is more in the night. So this degenerative joint disease we classify into various stages. There are about 5 stages. Stage 1 is the fibrillation, where patient complains of pain, fatigue. The cause of the source of the pain, the cause of the pain is fatigue. So patient complaint of pain at the end of the day, following activities. As the condition progresses, the duration of pain-free state is reduced. The duration of pain-free state is reduced. With the onset of the chronic synovitis, patient complain of morning pain and stiffness, because overnight there is accumulation of the synovial fluid. There is transient adhesion formation. So in the morning, as one gets up, one finds of stiffness and pain. As you move the joint, the accumulated synovial fluid will be dispersed, the transient adhesion breaks, so the pain and stiffness subside. And as one continues to do the activities, following activities, there is going to be pain at increased intensity. This is the first stage. And the fourth stage is the capsular fibrosis, where the joint range of motion is limited in the capsular pattern. Capsule is highly neural. So stretching of the tight capsule causes pain. So during walking, at your heel up, the knee is completely extended. In normal human locomotion. In the swing phase, during the toe phase, the knee is flexed to about 45 degrees. In the mid-swing, your knee is flexed to 67 degrees. During sitting, during squatting, the knee, 85 to 90 degrees of knee flexion is required. So in the capsular contracture, patient complain of pain due to stretching of the tight posterior capsule, that is during heel up phase of the gait cycle, where the knee is supposed to be extended. The knee is supposed to be completely extended. The knee is supposed to be completely extended. Now the posterior capsule is tight, so that is stretched. So during normal human locomotion, patient complain of pain due to stretching of the posterior capsule. Capsule is stretched during squatting, during step climbing, during sitting, etc. So that gives rise to pain. And the fifth stage, where there is subchondral bone involvement. Hello. So, in the fifth stage, where there is subchondral bone involvement, patient complain of continuous pain, and there, there is nothing left except replacement arthroplasty. Now coming to the clinical features. Now coming to the clinical features, usually elderly person, there is gradual onset of the pain. Pain at the end of the day due to fatigue to start with, and as the degeneration advance progresses, the duration of pain-free state is reduced, and in inflammatory stage, stage 3, patient complain of morning pain and stiffness. If there is acute inflammation, which is rare, patient will have continuous pain. And in the stage 3, like complain of pain during movement and activities that stretches the joint capsule, and in stage 5, there is subchondral bone involvement. Usually patient complain of almost continuous pain, and pain is more in the night. That is about the clinical feature. On examination, when you see the patient, you'll find usually patient come to us either in the stage 3 where there is inflammation, but mostly patient come to us in the stage 4 where there is capsular contracture. So we find usually there is a knee flexion deformity and genu varum. Genu varum suggests involvement of the medial compartment, and knee flexion deformity is due to capsular contracture. There is wasting of the vastus medialis. Movement is limited in the capsular pattern. Crepitus may be present. And tibiofemoral osteoarthritis is often associated with
A small technical problem in net or SV net or some power cut problem is there. Within 5 minutes, or will join in the webinar.
stop. Theoretical रखना उतरे एलिमेंट no अगर किसी
Ma'am, please allow the video, ma'am. PP sir, video, ma'am. Hello.
Yes, he can share the video now.
Yes, ma'am. Sir is prepared, ma'am. Please allow the video, ma'am.
Yes, he can share.
Okay.
Hello.
Yes, sir. Please continue, sir.
Okay. So tibiofemoral degenerative joint disease often associated with patellofemoral osteoarthritis. So let me tell you something about patellofemoral. patella is a largest sesamoid bone which is embedded on the back of the quadriceps. And the quadriceps, normally what happens, the quadriceps pull is upward, whereas the ligamentum patelli pull is downward. So in this force system, this is a coplanar force system that is originating from a common point. And the resultant of this coplanar force system can be found out by the law of parallelogram. So when you draw a parallelogram in the coronal plane, then what happens? This is related to your Q angle. This is the ligamentum patelli force, and this is the quadriceps force. And after enclosing this parallelogram, this represents the resultant of the quadriceps force, which is directed upward and laterally. So during quadriceps contraction or active knee extension, the patella is pulled upward and laterally. The lateral pull will be more if the quadriceps, the Q angle is increased. The Q angle increases with genu valgum, IT band contracture, anteversion, femoral anteversion, external tibial torsion, pronated foot, etc. condition. The lateral tracking is going to be more. On the posterior aspect of the patella, there are three facets that articulate with the femur. One medial, one lateral, and there is odd medial facet. This odd medial facet is usually, it is non-articulated, it doesn't articulate with the femur. So the articular cartilage lining this odd medial facet is soft. But during lateral tracking dysfunction, every time the knee extends, patella track laterally. So this odd medial facet becomes articulatory. It is compressed against the femur. Since it was not acquainted with the compressive force, it fails to withstand that load and it may undergo degeneration, giving rise to anterior knee pain. Every time the knee extends, the patella track laterally. As a result, the lateral patellar retinaculum, the vastus lateralis, etc. structure will be short over time, and stretching of that structure give rise to anterior knee pain. As the patellar track laterally, the medial patellar retinaculum will be subjected to greater tensile stress. Over time, there develop chronic inflammation, and as a result, the medial patellar retinaculum becomes fibrous and thickened due to fibroblastic proliferation, and that chronic inflammation again give rise to anterior knee pain. Then, resolving this quadriceps force, that is the resolution of the quadriceps force in the coronal plane. Now, if you resolve the quadriceps force in the sagittal plane, again the quadriceps pull is upward, ligamentum patelli pull is downward, emerging from the common point, that is the center of the patella. The resultant can be found out by the law of parallelogram. So this is the resultant force. This force is directed anterior to posteriorly. So it is otherwise known as patellofemoral compressive force. This force compresses the patella against the femur. And when the patella is compressed, there is sustained compression without relaxation of the patella, then that will lead to degeneration of the articular cartilage lining the undersurface of the patella, giving rise to patellofemoral osteoarthritis. So that is the reason why person with anterior knee pain, usually we advise them to avoid all activities with the knee bending, because as the knee bends and more and more, anterior to posteriorly directed patellofemoral compressive force increases, precipitating degeneration of the patella. So this should be, activities with the knee bending like sitting in the floor, squatting, step climbing, etc. should be avoided. Now, I was telling there is a genu valgum. In standing, there is about a 10 degree of genu valgum. So with genu valgum, the lateral compartment is loaded more, medial compartment is distracted. And if you drop a plumb line from the center of the head of the femur, it is said that passes at the center of the tibia. So which means both the medial and lateral compartment of the tibiofemoral joint should be equiloaded. Equally, they should be loaded. If there is a genu valgum, lateral tibiofemoral compartment is compressed, so that is supposed to undergo degeneration. And when the wet line passes at the center of the tibiofemoral joint, both the compartments are loaded equally. Again, why the medial compartment degeneration usually we find? There could be some other associated factor. So what is that factor? That there is not, I think no literature mentioning that. So probably that could be due to external rotation of the hip joint. That could be, around the hip joint, external rotators are stronger than internal rotators. There is no muscle. There is no muscle around the hip which primary action is internal rotation. But you have got strong hip external rotators like piriformis, your gemuli, obturators, etc. When you lie, when you stand, always the hip, there is a tendency of hip external rotators. So due to this muscle imbalance, the external rotators undergo adaptive shortening. If you, in non-dead bearing, can you rotate your both the legs? You can see with this rotation, with the internal rotation of the thigh, the knee is valgoid, whereas with external rotation of the thigh, there is genu valgum. In weight bearing, similarly, can rotate it. You can see which rotation, this side, external rotation, there is a genu bharam, whereas the other side, with internal rotation, there is genu valgum. So what do you want to say? When there is a external rotators are tight, external rotators are strong enough, that result in bharam of the tibiofemoral joint. That probably load the medial compartment to a greater extent and predisposing to degeneration, progressive degeneration of the medial compartment. That could be one of the factors. So when the patient comes to us with osteoarthritis, usually, they come either in the third stage or the fourth stage. Now coming to the management.
Sir, PP sir, video is not visible, sir. Your video is not visible, sir.
Yes, yes. Actually, there is failure in electricity.
Okay, sir. Okay, sir. I
Okay.
understood.
Okay.
Okay.
So when the patient comes to us with, say, degenerative joint disease of the knee joint, whether it is patellofemoral or whether it is tibiofemoral, in stage 1, stage-wise, we will discuss the management. Stage 1, there is the cause of the pain is due to fatigue, and the patient education is very important here. You have to explain the patient, see, it is a primarily disease of the articular cartilage, which is avascular, which cannot be repaired, which cannot be replaced. So this disease is a progressive one. This is a progressive condition rather than the disease, you can say. So what you have to do? You have to protect your joint. As you protect your joint, you can protect your degeneration of the articular cartilage, prevent degeneration of the articular cartilage and protect your joint easily. So for protection, we have already discussed under the biomechanics, one should avoid activities with the knee bending. Minimize the activities with the knee bending. If one is overweight, reduce the body weight. People ask, should I go for the walking? Walking is a weight-bearing activity. Your joint is loaded, and joint loading is the cause of degeneration. So walking is not the answer to reduce your body weight. Then immediately they ask, how can I keep myself fit? How can I reduce my body weight? So next, usually we ask, by walking all these days, you have not kept yourself fit. Neither you have reduced your body weight, nor you have kept your knee joint protected. So there are other means also to reduce your body weight and keep yourself fit. And literature says weight-bearing exercise has similar effect as non-weight-bearing exercise. The best thing is swimming, but in our context, swimming may not be possible. But one can do various non-weight-bearing exercise, like lying in the bed, doing various, like cycling in the air, abduction, adduction, rotate the leg. The duration of the exercise is important. At least 40 minutes one can do the exercise to reduce the body weight and keep yourself fit. One should use a good footwear, because if it is a soft footwear, it is going to absorb the ground reaction force, the shock. So the lower limb joints, your spinal joints can be protected to some extent. And most important is, if there is a deformity, particularly knee flexion deformity, that has to be corrected. Tight structures like piriformis, posterior joint capsule, hamstring, gastrocnemius, etc. muscle should be stretched, and the muscle, hip adductor also has to be stretched, and quadricep has to be strengthened. Both quadricep, hamstring should be strengthened. Quadricep strengthening is more important, because in most of the cases you find there is gross wasting of the vastus medialis. Strengthening of the abductors is also important. Stretching of the gluteus is also important. When you strengthen the gluteus through IT band, it acts as a knee extensor. Your TFL through IT band, it acts as a knee extensor. Thereby the knee can be protected, knee can be deloaded to some extent. Since there is a varus deformity, the medial structure is expected to be tight, like medial hamstring. So strengthening of the lateral structure, like hip abductor, may help in overcoming that, strong adductor force, some, strong force on the inner aspect of the knee joint, to minimize the genubharam deformity, minimize the progression of the genubharam deformity. You can go for if there is already a genubharam, you go for the footwear modification, like lateral heel and sole raise, so that the medial compartment can be deloaded and weight can be transferred on the lateral aspect. So various exercise, like in the stage 1 and 2, we teach, educate the patient, the don'ts. What are the don'ts? What are the do's? Come with the do's, your static quadricep exercise one can do, that ask the subject to tighten the thigh, hold it for about 5 seconds, relax for about 10 seconds, and do it regularly. It can be done in sitting, it can be done in standing, it can be done in lying position. Static gluteal exercise, tighten your, hold it for 5 seconds, relax. Then you can do resisted Patellar, just use wet cup or the sandbag above the ankle joint, ask the subject to lift it, hold it for 5 seconds, take it down, rest, and alternate leg. Every hourly 10 times can be done. The best thing, another alternative is, you can use We can use TheraBand, tie the TheraBand above the ankle joint, alternate leg, straight leg raising. Again, the resistance of the TheraBand can be done to strengthen the quadriceps. Move the leg out for strengthening of the hip abductors and take it, relax it. As you move the leg out, abductor work concentrically. As you relax, abductor work eccentrically, the muscle is going to be strengthened. Every hourly one can do. In a working hour, when you are free, 10 times, every hourly can be done at home. So stage 1 and 2. Stage 1 and 2, home exercise program is prepared. In long sitting position, you keep a pillow under the heel and ask the subject to touch the toe. Thereby what happens? The posterior capsule can be stretched, hamstring can be stretched, gastrocnemius can be stretched. The knee is off the ground by the gravity, by the weight, the posterior joint capsule can be stretched. If you want to stretch it, more, then you can keep a sandbag on the knee in this position. But ensure that the toe faces up. So when the toe is out, usually there is a tendency of external rotation. So in that condition, the lateral structure will be stretched, not the posterior structure. So ensure that the toe, this is a very small thing, but that matters a lot while educating the patient. The toe should be touching, toward the ceiling, or both the toes, great toes should be touching with each other. That can effectively stretch the posterior structures. Then adductor stretching has to be done. Since there is a bharam, tendency of Janu bharam, the medial structures should be stretched. In standing position, spread both the legs with hand support till one feels discomfort in the groin or the medial aspect of the knee. Maintain it for 2 to 3 minutes, morning and evening. Or alternately, you can do it on single leg, standing, then keep the leg on a stool and move the trunk away from that, unilateral. This is relatively, the elderly person will find it relatively safe. Stretching of the gastrocnemius can be done at the edge of the step. Stand on the ball of the metatarsal at the edge of the step, and the foot is out. Allow the heel to move down, so that by the body weight, the plantar flexor can be stretched. Now coming to the, suppose it is in the third stage, but there is chronic synovitis. When there is inflammation, in inflammatory condition, therapy role is very little, less. When it is acute inflammation, definitely no manual therapy. Laser, in electrotherapy, laser is found to be most beneficial in synovitis. Along with the laser, we encourage the patient to do isometric contraction, no manual therapy. Straight leg raising one can do. And if it is the chronic synovitis, ultrasound help in resolution of the inflammation. Laser also can be given. In acute synovitis, if you do not have the laser, intropharyngeal therapy can be used. And in any stage, Faradic stimulation is available in all the clinics. You can use strong Faradic stimulation to the vastus medialis muscle. When there is pain, usually the muscle is inhibited, muscle activity is inhibited. That is the reason within a few days, with little swelling inside the joint, biomo cross wasting develops. So that should be facilitated by Faradic stimulation. Your adductor stretching, adductor strengthening by squeezing the knee. Keep something, a towel, just squeeze my hand. That also facilitates, squeeze my hand, facilitate biomo contraction. And strengthening of the biomo can be done in that way. Then when usually patient come to us, in the first stage where there is capsular contracture. By the time patient has developed genu bharam, knee flexion deformity, So what do? Just you can rotate both the leg internally. With the straight knee, rotate both the leg internally. This is very, very effective in relieving the knee pain in degenerative joint disease. There what happens? If we hip internal rotation, stretches the external rotator, sustain stretching. And you can see with this internal rotation, Jenu Bharam it tends to be corrected. We have also discussed with internal rotation there is a valgus. So Jenu Bharam tends to be corrected. Okay, you can apply traction so that knee flexion also will be corrected to some extent. This can be done every morning and evening. Hold it for some time, 2 to 3 minutes. Patient himself can do. Other patient who, both the great toes to touch with each other and internally rotate it. At home he can do it. But next is we go for the piriformis stretching. Piriformis stretching is very, very important. The role of piriformis we have discussed. Hip external rotation tends to give rise to Jenu Bharam, loading the medial compartment to a greater extent. So stretching of the piriformis is very important. So how to stretch the piriformis? Piriformis, though it is a strong external rotator, it acts as a hip abductor, strong hip abductor with the hip flex to 60 degrees. So with the hip flex to 60 degrees, you can adduct the thigh. You can adduct the thighs. But here the problem is, usually what you find, simple adduction of the thigh lead to rotation of the pelvis. You have to keep the pelvis fixed. Then only the piriformis can be effectively stretched. So to fix the pelvis, what you do with the hip flex to 60 degrees, you apply pressure along the long axis of the femur. Keep your hand on the bent knee, reinforced by your chin, press along the long axis of the femur so that the pelvis is fixed. Now you adduct. Till one feel the discomfort from the lateral axis of the hip joint. You can do to avoid pelvic rotation. Bilateral piriformis stretching can be done. Both the hip flex to 60 degrees, thigh cross, adduct. There is no chance of rotation of the pelvis, any trick movement. You can teach this one, the patient to do. Hold the right knee by the left hand, left knee by the right hand, and pull it out. Hold it. Sometimes what happens, while doing this piriformis stretching, patient complain of pain in the inner aspect, in the groin because of impingement. So to avoid that, what you can do, you just adduct with internal rotation. You keep the bent knee within your axilla, your forearm passes under the leg, and try to move the foot outward for internal rotation of the hip joint, whereas the axilla, you are applying pressure along the long axis of the femur and adduction. So combined adduction and internal rotation can effectively stretch the piriformis. So these are the various ways. And there is another alternative also by using your MET sideline. To make the subject lie in the sideline position, at the edge of the bed, hip flex to 60 degrees, thigh adducted, foot behind the opposite knee. In this position, internally rotate. Try to move the foot out. But here, the problem is fixation of the pelvis is a problem. In this position, what you do? Keep the bent elbow or olecranes process over the piriformis. In sideline position, the piriformis can be visible. The top band of the piriformis can be visible above the greater trochanter. So you keep your elbow over the top band, reinforced by the knee, move the foot out, the thigh is adducted, internally rotated. Then with a sustained compression, ask the subject to, can you press my hand down by the foot? You apply MET technique. Ask the subject to press your hand by his foot with about 20 to 30% of the maximum voluntary contraction. Hold it for 5 to 10 seconds. Relax. As you relax, you move it little more out for internal rotation. Rest for some time, and again repeatedly 5 to 10 settings can be given. And during this maneuver, let me tell you, sometimes patient complain of some discomfort on the medial aspect of the knee. That has to be taken care. Because of the stretching of the structure, patient complain of pain. Now coming to, if somebody has got a knee flexion deformity, that should be corrected by force, serious force flexion or serious force flexion. Subject in supine lying position. Keep one hand on over the front of the knee, other hand over the heel. Then you side bend your trunk. As you side bend your trunk with the elbow stretch, the knee is pushed backward, whereas the heel is raised upward to equal an oppositely directed force by using the body weight, by therapist body weight. No need to use your muscle force. Stretch the posterior capsule. You can go for the, plantar flexor stretching also. The tibia is supported above the ankle joint, the foot is supported by the forearm, and you pull the heel down while pushing the foot up with little inversion. With inversion, what happens? The foot is locked. The foot is locked. So that dorsiflexion exclusively occur in the ankle joint. Otherwise, usually, sometimes people do the mistake with the eversion, the foot is pronated, foot is relaxed, there may occur dorsiflexion in the mid-tarsal joint or tarsometatarsal joint. So this thing has to be taken care of. Just invert or supinate, lock the foot and do the dorsiflexion for effective stretching of the plantar flexor. Then we go for the, tibiofemoral osteoarthritis is almost accompanied, almost associated with patellofemoral. So we give patellar mobilization. I was telling you, the lateral patellar retinaculum masters laterally. These are the structures which are taught. Medial patellar retinaculum is chronically fibrosis. So patellar mobilization is required. You keep the thumb on the use your body weight and mobilize the patella in all directions, all possible directions. Usually we mobilize lateral to medially, but most often we find a trigger point somewhere, somewhere, maybe on the lateral aspect. So we try to locate that trigger point, and that needs to be mobilized. Inferior to superior, keep the heel of the hand on the inferior pole of the patella, elbow straight, push it. Keep the heel of the hand on the inferior pole of the patella with the elbow straight. Forearm should be as horizontal as possible and push the patella up. So when usually what the people do, they keep the hand like this, forearm vertical. If you keep the forearm vertical, you are compressing the patella against the femur. So if you want to simply mobilize it, ensure that without compression, your forearm should be as horizontal as possible. If you move a little away, then only your forearm will be horizontal. So that your force will be exclusively mobilizing without any compression. This is very small thing, the direction of the force. It's depending on the direction of the mobilization, direction of force to be applied, and the hand position that matters in that case. Then you can mobilize the knee joint by either using your Catalan concept or Cartilage concept by what you do? We do little modification, the leg remain between your thigh. So when the patient leg remain between your thigh, you can apply distraction. Tibiofemoral joint is degenerated, joint space is reduced. When in that case you give mobilization, there is chance of friction and further degeneration, further damage, sorry. So by your thigh to apply distraction. With one hand you are keeping the femur fixed, his leg is grasped between your thigh and apply distraction, then you can apply posterior to anteriorly directed force. Just pull the patella posterior to anteriorly. The knee is already placed in the end range. So that is going to improve your posterior to anterior glide. That is going to stretch your joint capsule and improve the extension range of motion. Sometimes patient complain of pain on the medial aspect of the joint. Complain of pain on the medial joint line. There is localized point they show. And on examination, you'll find that point coincides to the medial collateral ligament. So to find out the medial collateral ligament, the knee is in semi-flexed position. Place your thumb just lateral to the patellar tendon on the tibiofemoral joint line. The gap can be felt easily. Move the thumb backward. You will reach a point where the tibiofemoral joint line is inside medial collateral ligament. Then place the thumb over there. Then you can give deep transverse massage. Then dramatically relieve the pain in one sitting. Or alternately, we keep the patient lying in prone position, then place the thumb on the medial collateral ligament or the joint line, with the other hand externally rotate. With the compression maintained over the medial collateral ligament at the tender point, you externally rotate. Medial collateral ligament is stretched with external rotation and abduction. So this external rotation is going to elongate the adaptively short medial collateral ligament and relieve the pain. Make the client lie in prone position with the foot out. Then soft tissue mobilization can be given. Because the posterior capsule and soft tissue structure are tight, so the soft tissue mobilization also relieve the pain to a greater extent. Soft tissue mobilization on the posterior medial aspect, that is more important. Then mechanical traction can be given in the department while giving traction. Suppose you want to give traction in the machine, again ensure that the hip is in neutral rotation. The toe faces towards the ceiling. Number one. Heel should be resting on it. Knees unsupported. Then along with that, the femur by using a belt. Simple belt is not available, just tie a you can tie a bed sheet along with the couch so that the femur will be fixed properly. And, there will be stretching of the all periarticular structure, and that will also relieve the pain. Then people give various knee brace and all. Knee cap, people also come and ask whether should I use the knee, what is that, the knee cap or not. But use of the knee cap, when one uses the knee cap, yes, he feels secure, he feels comfortable. But prolonged use of the knee cap result in wasting of the muscles. When the muscle is wasted, joint protection is lost, joint proprioception is lost. So one becomes dependent on that thing. So usually we recommend, suppose comfortable while going out, you can use, but try to reduce the use as much as possible. Even in very chronic, osteoarthritis, very severe, with all this manual therapy technique, patient, you can find the medial compartment, there is no space. And if you go to any physician, any surgeon, they advise for the replacement. And refusing the replacement, at the last resort, they come and report to us. And when you give them, and when you treat the patient, they find that regret relief of the symptoms. With this, from my side, the session conclude. If there is any question are welcome. Anything to be discussed, that is welcome.
Please, any questions?
Thank you, sir, for the wonderful presentation. There are questions from the attendees. The first question is, what are the indications for a posterior capsule stretch?
When there is a knee flexion deformity, normally, our knee physiological, there is about 5 to 10 degrees of hyperextension. So when the extension is limited, obviously, posterior structure is tight and you have to stretch the posterior structure. And posterior joint capsule stretching is indicated in that case. When there is a knee flexion deformity, in that case, you go for the posterior capsule stretching.
Next question is, in osteoarthritis of knee joint, why is it more common for the medial joint space to reduce as compared to the lateral joint space?
That is what we have discussed, Normal anatomy, if you go by the normal anatomy, there is a genu valgum of 10 degree. Because the medial femoral condyle extends distally and the lateral. So, when there is a genu valgum, obviously the wet line should fall on the medial compartment, lateral compartment. There is lateral compression and medial distraction. So by that aspect, the lateral compartment osteoarthritis should occur. Then second one I told, if you drop a plumb line from the center of the head of the femur, that wet line that passes, book says that passes through the center of the tibia. So that both the compartments should be equally loaded. But practically when you come to the patient comes with medial compartment osteoarthritis. So probably there is no literature mentioned. Probably I think, in weight bearing, non-weight bearing, we have demonstrated with external rotation of the hip how there occurs genu bharam. With internal rotation of the hip, when there is internal rotation, there is genu valgum, and external rotation, there is a genu bharam. So since external rotators are stronger, and I mentioned there is no muscle around the hip which primary action is internal rotation. So there is a huge gap between the strength of internal and external rotator. And in our posture also, when you lie down, 8 hours, 10 hours a day, our hip is always in external rotation. Muscle, number one, the posture by gravity. Number two, muscle imbalance. that result in adaptive shortening of the external rotators. And with the external rotators strong enough and external rotation attitude, there occurs genu bharam. So probably that is the factor that load the medial compartment to a greater extent and will disposing to osteoarthritis. We have just taken up a project on that also. We found there is a strong correlation piriformis tightness with the medial compartment osteoarthritis. So that is the reason when you go for this internal rotation, either with the straight knee, you rotate the hip internally, that stretches the piriformis, that tends to correct the genu bharam and patient find relief of the symptoms.
Sir, in ONE, at which stage can we go for orthotic intervention, and how effective is it in reducing the pain?
See, there are various stages, like I told. In the first stage, there is fibrillation. Second stage, there is a fissure. Third stage is inflammation. Fourth stage, capsular contracture, and fifth stage where there is subchondral bone involvement. When stage 1 and stage 2, usually you educate the patient regarding the don'ts, and you teach home exercise program, there is stretching, strengthening exercise program, and the do's and don'ts, so that one should protect the knee joint. You have to explain the patient, see, there is no cure to it. More you take care of your joint, you are safe. You can protect your joint in progression of the osteoarthritis. There is no medicine to it. That is very important thing. There is no medicine that can help in regeneration of the avascular articular cartilage. The only option left is replacement arthroplasty. If you are ready for your replacement arthroplasty, you do not know how much successful it is going to be. And it is a costly affair that you have to caution the patient so that you will realize the importance of physiotherapy. You will realize the importance of protection of the joint. Then only you will do it. And when the patient comes to you, see, but there is inflammation. I told acute inflammation, acute synovitis. Your laser therapy is helpful, and chronic synovitis, Manila. And in chronic synovitis, either you can use laser, you can use ultrasound also. And regarding the orthosis, I told patient is usually given a knee cap. And when they use a conventional knee cap, which is tight at both the ends, the other the patient comes, there is swelling of my foot. Obviously, that is going to obstruct the venous return and one develops swelling of the foot. And as one use the, if it is a good fitting knee cap, patient find relief. So when you find relief without doing nothing, obviously you will depend on that knee cap. But by using that knee cap, what happens? Muscle becomes disuse atrophy. Joint become lax. Bharam deformity is going to increase. Flexion deformity is going to increase. One becomes dependent. So again, we discourage the patient using this knee cap particularly. And regarding the orthosis, when there is a genu bharam deformity, very mild genu bharam deformity, we recommend lateral heel and sole raise, footwear modification with lateral heel and sole raise. When the lateral heel and sole is raised, the wet line shift. In genu bharam, the wet line is in the medial compartment, that shift laterally. So the medial compartment is deloaded. Load may be coming on the lateral compartment. That is the benefit. Then they go for, in genu bharam and flexion deformity, there are various knee orthosis available. There are certain, they claim it has got a traction effect, distraction knee orthosis. And on weight bearing, how much it will distract, how much the distraction will maintain, I have a strong doubt. People use that orthosis, take the X-ray before and after this thing in non-weight bearing. And obviously when it is a non-weight bearing, there will be distraction. But on weight bearing, how much, distractive force you will apply by the orthosis so that the joint distraction will maintain on weight bearing. And can the patient tolerate this amount of distraction? Obviously not. So this deformity, even I told very severe knee flexion or bharam deformity can be corrected by physiotherapy. So as a physiotherapist, I recommend you will go for more of the exercises rather than prescribing the knee orthosis. Yes, when the patient come in the terminal phase, that is stage 5, there is no other option. You have to, there is laxity, lot of laxity in the joint. If the patient doesn't agree for the replacement arthroplasty, you have to go for the orthosis, but not in any of the 4 stages. In physiotherapy point of view, I am telling. And in osteoarthritis, physiotherapy is the only answer. No medicine can cure. You have to believe that, and you have to make the patient believe also.
The next question, what is fat pad syndrome and how can we manage it with manual therapy?
Sorry?
What is fat pad syndrome and how can we
Fat pad
manage it
syndrome.
with
Okay. In fat pad syndrome, there is a fat pad on the inferior pole of the patella. Usually patient complain of pain on the inferior pole. So in that case, you mobilize the patella only. You simply mobilize the patella. There is a tender point, inferior to superior gliding of the patella, keeping your heel of the hand at the inferior pole, elbow straight, forearm should be as horizontal as possible. Try to push it. And number 2, straining of the quadricep also help in that case. Particularly your vastus medialis straining also help in that case. And people go for, various tapping technique and all they use, but I'm never used. I don't have any experience in that.
The next question, what is the role of electrotherapy in relieving knee pain? Would you elaborate on which modalities would be beneficial?
I am very poor in electrotherapy. I believe on my hand. So when, the problem is mechanical, osteoarthritis is a mechanical problem, I believe. Yes, in stage 3, there is an inflammatory condition. So when the pain is mechanical, so when the pain is mechanical, your manual therapy is going to help. And when the pain is chemical, that is inflammatory, yes, electrotherapy is going to help. So I have already mentioned, in case of stage 3, where there is chronic acute inflammation, synovitis is there, laser is helpful. It's quite helpful in relieving the symptoms. Then you can use, what is that? Pulse galvanic stimulation also, pulse galvanic stimulation or interferential therapy also helps in that case. And if there is a chronic synovitis, then ultrasound is helpful, laser also helps. And in stage 4, where there is a capsular contracture, before stretching the capsule, ultrasound can be used. It has got the heating effect. It will help in elongation of the collagen tissue. It has a biological effect also. So prior to mobilization can be used the ultrasound. And we always recommend using strong Faraday stimulation to the BMO in any stage. Sometimes, if the patient can afford, tell them you can purchase a pocket electrical stimulation, take the stimulation at home, vastus medialis particularly, and that helps. Nowadays, high tone therapy has come. They claim that help in regeneration of the articular cartilage. This is literature also. There are a lot of literature mentioning that, and we have undertaken certain research project on that, and the result is yet to come.
Sir, Vivek sir from Indore is sir. He is asking one question, sir. Vivek sir, from
Okay.
Madhya Pradesh.
Okay.
Sir, Vivek sir. You can ask,
Yeah.
sir. Sir, Vivek, sir.
Hello.
Yes.
Please ask, sir.
Sir, what is the SLR angle? Sir, what is the hip angle in the SLR to strengthen the quadriceps?
SLR. Straight leg raising you are asking about, see there are various literature, some says SLR, registered SLR, you can do just straight SLR, some says SLR can be done with external rotation. And the literatures, both in strengthening the quadriceps, the effect of both SLR, simple straight leg raising with the hip neutral or SLR with the hip external rotation, the outcome is almost same. So what you do, you simply ask the patient to do the SLR and hold it at about 45 degree or so, that 5 seconds, then relax, alternate leg he can do. Even if one leg is affected, you can recommend for the bilateral SLR, because when one leg is affected, the other leg bear the more load. Usually patient work with the limping gait, antalgic gait. So bearing load more the opposite side over time may be also involved. So that also has to be taken care equally.
Sir, my question, sir. Sir,
Yes.
is there an importance of sartorius in osteoarthritis, sir? Sartorius muscle, sir.
I don't know. Sorry, I don't know. Sartorius, is a hip flexor, knee flexor. So no, I can't say. Sorry.
Because it is an external rotator.
Maybe,
Okay.
but that is a very poor external rotator. Sartorius is a very poor external rotator.
Okay.
Maybe, if you say, since it is a part of the pes anserinus, it inserted on the medial aspect, like gracilis and all, maybe it is contributing to some extent. No, but no, I doubt, because it is abductor, it is not adductor. Sartorius is abductor also. No, I can say.
Okay.
We'll take one last question.
Yeah.
For in case of patients having knee inflammation, can we do a soft tissue mobilization, and how do we go with the treatment?
No. When there is inflammation, there is swelling. There is swelling, there is inflammation, absolutely no manipulation, no mobilization, nothing. There is no literature mentioning any manual therapy in inflammatory stage. You see, when it is a chemical, there is accumulated inflammatory exudate give rise to pain. So chemical pain has to be dealt chemically. Let it be very frank. And mechanical pain has to be dealt mechanically. So maybe some inflammatory condition, you can use thermotherapy, electrotherapy, but not manual therapy. Yes, when there is pain and spasm, grade 1, grade 2 mobilization can be given. But grade 1, grade 2 mobilization to relieve the pain, relieve the spasm, that is very small amplitude movement that can be given. But soft tissue manipulation definitely. See, when there is inflammation, there is pain, there is spasm. See, there is a very wrong concept. I don't know why the people, all disciplined people believe in that. When there is spasm, you relieve the spasm. You give analgesic, you give muscle relaxant to relieve the spasm. You give, in physiotherapy, you say you give ice to relieve the spasm. Spasm is not the cause, spasm is the manifestation. There is a problem somewhere else, and this is manifested with spasm. Will you treat the cause or will you treat the spasm? Spasm is a guard. It is guiding you. It is cushioning you. There is problem. You take care of the problem. By relieving the pain, relieving the spasm, you continue to do the activities, continue to do the movements, the problem is going to aggravate. So, I always believe you treat the cause, automatically the spasm is going to be relieved. automatically the pain is going to relieve. Automatically the range is going to improve. Automatically the strength is going to return back. So finally I'll say, the strength of the physiotherapist is our evaluation, our physical evaluation. Now the medical treatment is dependent on investigation findings, but most of the cases, the problem doesn't correlate with the investigation finding. We get a lot of patients, MRI shows PIVD, patient undergo surgery and report to us with same problem. That proves that investigation finding doesn't correlate with the symptom always. So when you physically evaluate the patient and whatever physical diagnosis is made, that is more reliable. I am not telling, it is not my own statement. It is given in the literature. And the literature are not made by the physiotherapist. Most of the literature are made by, the physician and the surgeon also. So you have to develop your examination, evaluation skill, physical diagnosis skill. Treatment is not very simple thing. Anybody can apply the treatment. Once you come to the diagnosis, then treatment is an easy thing. So physical diagnosis has to be made through proper, thorough physical evaluation. Education of the patient is important. So now, 21st century, it is the lifestyle diseases, it is the stress, it is the occupational problem, which is going to be more. And in this time, physiotherapy is going to be the first line of healthcare profession. So to meet with the demand, we have to improve our background knowledge of anatomy, biomechanics, and the skill instead of applying the modalities. Generally, we can prove ourselves one of the most efficient. Let the society, let the government not recognize. Let the society recognize you. The society is going to spread the importance of the physiotherapy. From patient to patient, patient will go. Let the orthopedic surgeon doesn't refer the patient. We'll get the patient from the patient. So have to improve our skill, evaluation skill, diagnostic skill, physical diagnosis. Our diagnosis is physical diagnosis. By clinical evaluation you do, that is more reliable than going for the investigation and pathological diagnosis, which is less reliable. Particularly in the musculoskeletal condition, 90% of the cases are ours, can effectively treated by the physiotherapist without any medical intervention. Okay, that's
Okay,
all.
sir, thank you so much, sir.
Thank you.
Sir, thank you so much for accepting IAP State Andhra Pradesh webinar. And I am very thankful to Central IAP technical team, Sanjuja sir, Ruchi ma'am. And once again, I am very, very thankful to PP sir. Namaskar, sir.
Thank you, dear. Thank you.
Yes, sir.
Open the video, Uttara.